Hello, everyone, and welcome to our session on inclusive care. So we'll get started straight away. So we've got as much time as we can have. So we're going to start with the beginning as we think about LGBT patients by defining what LGBT means. So it can be broken up into sexual orientation. So that's lesbian, gay, and bisexual. And sexual orientation is how someone feels sexually about different genders. And it's important to remember sometimes activity doesn't always mean orientation. And then the T refers to gender identity. So this is how somebody would identify their gender. And you might also see LGBT with different suffixes at the end. So you can see it with a plus to be more inclusive of other sexual and gender minorities. You can also see it with IQ plus, which is what we use as a charity for intersex and queer people. And you can also see location specific ones. So you will sometimes see things like 2S, which is two-spirit, and that's a North American third gender. All very appropriate, especially when you're thinking about the broader community. And if you're unsure which one to go with, LGBT is a good inclusive standard. So if we think about sexual orientation, this is some British data, but 5% of British population at the moment identify themselves as LGB. So we see this more prominently in people who identify as a mixed ethnicity and also in the other category. But also you can see from these yellow bars that are particularly high, there's high rates of prefer not to say. So this gives us the idea of potentially there might be more people still, or maybe our questions aren't necessarily asking for the right things. It's also important to note that younger people are more likely to identify as a sexual orientation other than straight. And we see this very much so in 16 to 24s with a high rate of bisexual responders there. You can see the data goes down over time, but I'd remind people that's not that people are less likely to identify in this way over time. It's much more of a generational effect. And we can see this a little bit more when we start looking at American data and how they actually take a look at it. So in America, self-identification as LGBT has gone up over time. And we can see when we break it down by generations that there is a really large difference between people born in the traditionalist era and the latest Generation Z. So you can see for LGBT responses, it's gone from 1.3% of the population up to 15.9. When we think about it, breaking it up into that LGBT that we discussed earlier, some prominent ones to point out, as we saw with young British people, we saw bisexuality had a very stark increase, same in America. And we can also see with trans people, this percentage has gone up as well. So it's just to give you an idea that this is something that's happening all over the world. It's a natural phenomenon of human behavior, and it's not necessarily a trend, as some people might otherwise describe it. So let's break down what it means to be trans so people can fully understand what we're talking about. So when someone's born, they have what we call a natal sex. So this is their body's makeup, how they come out of the womb. And this can be described as either male, intersex, also known as variances in sex characteristics, of which there's over 40, and female. What we tend to do here in the UK, once we see this, is a doctor will assign the sex to the patient. So they will make a judgment based on what they can see, and they will either choose male or female on their medical records. And this then impacts that person's legal sex. So over time, the things they're able to access, their pensions, their prisons, etc. But also it gives us a way that we assign a social gender onto young people and the way we bring them up. So if somebody was assigned male at birth, they're likely to be brought up as a boy, boy clothes, boy toys. But when someone develops their own idea of gender, that's when you start to come into your own and you start to understand who you are as a person. And then somebody might identify as male, female, or non-binary, and there's many other labels as well. So when we're talking about trans people, what we talk about is when there's incongruence between someone's assigned sex and someone's self-ID. So I put some lines here to show you what we mean by incongruence. So anytime there's a cross over this line, someone might be referred to as trans or might identify in that way. So if we break this down by common labels that we use, cisgender refers to someone who was assigned male at birth, but may identify as male. And it's the same for females. So there you see, there's no incongruence, cisgender. That's the majority of the population. When we think of trans women, this is someone assigned male at birth who IDs as female. And then conversely for trans men, someone assigned female at birth who is male. And then for non-binary people, they might be assigned either sex, but they identify outside of the ideas of male and female. So therefore they might identify themselves as trans. So I like to think of gender as a bit of a spectrum, and the best way I can represent that is in a triangle. So we have at the top of the triangle, female. So what we know to be female in the social context, that idea of gender. And we also have male, and we also have third gender. So this comes back to what I was talking about earlier with Two-Spirit. There's multiple third gender cultures across the world. And it's important to identify that third genders they're distinct from male and female, and they have their own social norms and social behaviors. And that's why they're separate on this diagram. We also have in the middle, people who maybe don't have any sense of gender. They refer to themselves as agender sometimes, and they may feel this in varying degrees. So this is why you have that difference in saturation across the graph. So someone who identifies as male might position themselves in the bottom right, identifies as female in the top, and someone who's non-binary could be anywhere inside this space. So it gives us an appreciation that if someone is telling you they're non-binary, there's actually quite a broad amount of gender experience they might be having. So it's important to think it's not one size fits all. And this is why questions that are much more reflexive and open-ended are much better when you get to know people, beneficiaries and patients, so they can tell you who they are rather than making a snap decision. As some people sometimes feel a non-binary person has to exist in this one-dimensional line between male and female, and that gives us certain assumptions about how they should present, when it's really not the case and there's a much broader picture at hand. So why is all this important? So especially when we think about these numbers and the increase in people in identifying this way, these are the patients of the future, and they may want to access our services in a particular way that feels right to them. And we should be prepared for that. Our services should be able to support patients in the way that they feel best represents them as a person, their community, and their support networks. It's also important to think about personalized care and how we're going to support people long-term, because Macmillan here in the UK estimates that by 2030, 4 million people will be living with cancer. So if we think about that in regards to the amount of people, that might be 636,000 people actively living with cancer. So they'll be accessing different services. That, of course, is all cancers. But if we think about ovarian cancers being 4% of all new cases in cisgender women in the UK, it gives us a way to think about, okay, we know this. This also might then refer to lesbian and bisexual responders if we're thinking about our community. But also this comes from CR UK data, and they're not actually looking at trans data. So we're also missing part of the picture there and thinking about, again, are there any particular risk factors or differences in our service we need to provide and make sure people feel included? So when we think about how people may be marginalized or excluded, it's important to think about all the different ways they might be. So obviously we're talking about LGBT communities today, so that places us up around here with the sex and gender and sexual orientation, but they may also be impacted by other marginalized factors. So you can see there's different aspects of race, ethnicity, and religion. So there might be multiple things affecting people at one time. So if we think about it in the sense of marginalized, with somebody may be intersex, they may be trans, they may be bi or pansexual. And then what we can also see then, if somebody is marginalized, there must be someone else who has an aspect of power on the converse. So this can also be identified as privilege. And it's important to think of it in this way, that if you're not potentially in these lower marginalized categories, maybe you have a position of privilege where you can help somebody get over the barriers that they're facing. So if we see this fully, we can see the people who maybe have this power might be people who are cisgender, particularly cis men. They may be straight, they may be well educated, they may have different religions, or they may have different aspects of their personal life that suit society and the way that they live. So it's about identifying how you can help other people who are potentially less well off than you. And from this, we see things like sexism, transphobia, homophobia. These are the labels we have, but it's important to identify how they may intersect. And from that, we have Kimberly Crenshaw's idea of intersectionality. So when we talk about intersecting oppressions, what we're talking about is there are multiple oppressions we may face, but at times they can overlap and create unique forms of oppression. And in that, it's important to identify them and understand that experience may be even more difficult or unique and need additional support. So to give an example, somebody may be a Black woman, and therefore they may be subject to racism and misogyny in society. And Moya Bailey herself gives this the label of misogynoir, but also somebody may also be trans on top, which gives us trans misogynoir. And that's not to say that every intersecting barrier has a unique label. Sometimes they don't, they're harder to identify. But this is where it's important to, again, to identify people completely as a whole, And then also, once you've done that, look at your own services and your own organizations and think, are we reflecting these people fully? Are they welcome in our spaces? Do they feel that they're best represented? And then there's other ways to think about this. So beyond people and beyond your organization, there's the other impacts like bias in research. So we can also think about how this intersecting factor may mean that there's a lack of data in particular communities. So how can we best help them if we don't know their current situation? So I'm just going to go over the LGBT experiences of healthcare in the UK, just to give you a rough picture of what it's like out there for patients in general. So here we see that 23% of LGBT patients have seen bad remarks from healthcare providers, 14% avoid healthcare. This goes up to 37% when it takes into account trans people. Of the trans people that do attend, 38% have a bad time. 19% of LGBT people aren't out to any healthcare providers, and 31% of trans cancer patients aren't out to any healthcare providers. And 41% of trans people feel like their general health needs aren't being met or understood. And here we have the National Cancer Patient Experience Survey, which goes out to the majority of cancer patients. And this only in its data is looking at sexual orientation. It doesn't actually look at trans status yet, and it is looking at all cancers. But even from that, it's important to note that LGBT responders were more likely to feel like they weren't being spoken to in a preferred name. They were less likely to be treated with respect, and overall, they gave poorer ratings of care. So thinking about it from the healthcare experience, it's also then thinking about how they engage with additional services in third sector and how they're coming to us and what additional factors we should have in place in order to support them. So the other thing that comes up quite a lot is the language and the words around our community and how to do it right. So one of the things that people get a bit nervous about is pronouns. They're nothing new, and in English, they're very, very common. And fundamentally, they're just the word that replaces a noun in a sentence. So when we use personal pronouns, this is where you might hear people refer to he, she, or sometimes the singular they, which is the one I tend to use. And with this, it's important to understand even the use of they as a singular is not new. So to give a good example, here is something that was floating around the internet that I think was really useful. So I'm just going to read it out. Just found a wallet on the ground at Macy's, found the cashier, and together we tracked down the owner. They were so happy that I returned their wallet and they tried offering me cash. Of course, I refused because it's not their fault they lost their wallet. So that makes perfect sense. But still, there seems to be a slight reticence to people using singular they because it feels too novel. So the point to take away here is it's not a novel function of language. It's actually just people choosing to use it themselves when they don't want to be identified as male or female potentially. And it's a gender neutral form. And I would encourage people as well in their organizations generally to be using gender neutral language as much as possible. So if you have a newsletter that goes out that says ladies and gentlemen, switch it to everyone. Or if it just only says ladies or women the whole time, think about the fact that trans men might need to access your services and they may be being put off by things like that. So thinking about gender neutral language, another thing that can really help is moving away from highly gendered terms and moving towards specificity. So what exactly are we talking about? So this is where you can switch out women's cancers and be more specific with ovarian cancer if you have ovaries. This information is for anyone born with ovaries. When we think about pronouns still, a really good way to bring this into your day-to-day organization and interactions are simple things. If you're not feeling very confident to ask people's pronouns directly, you can put them in your own email signature, and you can put them in your Zoom or Teams calls, on your social media, or on name badges if you have them. And it's a good way to show that not only your understanding of pronouns, but also then any LGBT person accessing your services will see that and also see that you have a culture that's supportive. So specifically some gynae considerations in LGBT communities. Cervical screening is one that's been looked at quite a lot. And we can see that lesbian and bi women and trans men have lower rates of cervical screening. We've seen that 37% of lesbian and bi women have been told they don't need to be screened here in the UK, and that's obviously misinformation. And we've also seen that 14% of lesbian and bi women have been actively refused or discouraged screening. This normally happens in the case that, along with that misinformation, they're told by clinicians that they don't need to be screened because they're not having sex with male partners. And this is just not true. Anytime that somebody's had anything in the vagina, they should be getting screened. So we recommend it to everybody who's of age. When we think about other investigations like transvaginal ultrasound, it's also important to think about how lesbian and bi women and trans men maybe don't engage in receptive vaginal sex. So having anything in the vaginal canal may be uncomfortable. You may also see that trans men who have to go through this might be experiencing dysphoria around this part of their body. And dysphoria is the word we give to the particular form of mental discomfort that comes from issues related to your gender and your sex assigned at birth, and if there is that incongruence attached. So for example, you may end up supporting a trans patient who has to go for the screening or scan, and they're very nervous because it's not something that they are very comfortable with. They're afraid of the clinic environment, or they're afraid of the test itself. So thinking about clinics, they can be very, very gendered. We often see women's health centres, or we see signs about women's cancers. And again, thinking about people who may be gender diverse accessing those services, even down to the aspects of gender neutral toilets in those spaces. And also then thinking about the information and services that are around this as well, to make sure it's as inclusive as possible. And I hear directly from patients that I support that a lot of trans people are very afraid of where they're going to end up in hospital. So if they go in for inpatient care, where their ward will be, and the attitudes of the people around them. So it's important to understand that they have sometimes additional needs and concerns that need to be well met. And a good way to do this is with co-production. So if you are thinking about, okay, well, how can we as an organization get better? Sometimes it's important to remember that as much as we can't assume the barriers that people face, we shouldn't assume the solutions, and we should work with people to create these. So I would recommend to everybody, if you want to do a bit more of inclusive work, identify people in the community that can help, identify other organizations that potentially are more specific to communities that want to come on board, and give patients a voice, because they're most likely to understand what potentially needs to change, either in relation to their patient experience or the way that they access your information or support. And then other things that can be useful are looking at your own workforce. Is there anyone that particularly wants to take the work on? And that may not always be the person in the office who is LGBT. Sometimes we shouldn't assume that just because somebody is from a particular group, that they are the one to take on the work, because it can be quite a lot of emotional baggage, or also making sure we're not adding things on as a bolt-on to people's time and capacity, and bringing it into the core values of the organization so that they have the time to fully commit something and backed up by the resource. And then I'm going to pass over to Ovacome, who've been doing this pretty well.
Thank you, Stewart. I'm Imogen, and I'm here from Ovacome, which is the UK ovarian cancer support charity. And I think we did want to just start. We had a quote from.
It's on a previous slide. Let me go back to it. It moved.
I'm just gonna read it out for everyone. Or
okay.
I could just read it out for everyone. One of our members got in touch in 2018 and said this. So, I wanted to write to Ovacome about something that comes to mind most times I read your newsletter. I wondered if occasionally you might want to tell the story of lesbians and their partners and families in relation to ovarian cancer. Your newsletter stories often refer to husbands, but I don't think I've read one about a same-sex couple. And part of the power of what your newsletter does is help see people in similar situations living with the impact of ovarian cancer and feel less isolated. As a result of this member of our community getting in touch, we undertook some staff training with the LGBT Foundation and Macmillan here in the UK. We reviewed our communications and imagery, the stories that we were putting out, and we set up a focus group to dig deeper into some of the more specific issues and information gaps for the LGBT community. And as a result of this, we then took action to adapt our language to be more gender neutral and inclusive, as well as the stories that we're putting out in our newsletter and online communications. We worked with our expert advisory board to understand some of the issues better, and we also produced materials to raise awareness among healthcare professionals of this difference in experience for LGBT people. And that led us to this year doing a bit of an audit of what what we've done so far and assessing where the gaps might be. And this led us to then doing some more work this year to produce some information for trans, non-binary and intersex people born with ovaries, as we identified that there was a lack of information for this group of people. And then and also really set up our LGBT focus group as well to sort of further look into some of the specific information gaps. And I think, so you can kind of see that we've got this iterative process of consulting with the community, taking action, reviewing what we've done, and then doing the same again. So yeah, if you could go to the next slide, please. Thank you. And here we just wanted to kind of sum up the way that we try to address inequalities as an ovarian cancer charity. And Stewart's already spoken to some of the barriers that the LGBT community face, such as, you know, avoiding healthcare settings due to fear of discrimination or not accessing services that are too gendered. So I just kind of wanted to pick up on the fact that overall what underpins this is communication. So communication from the healthcare professionals, whether that's appropriate, the way that we communicate to the general population in our messaging and using more gender neutral language, and also just general awareness and information gaps, where something that we in our Pride campaign this year, we tried to highlight the fact that, you know, there is lots of misinformation out there, and people born with ovaries need to be aware of their risk of ovarian cancer. And the ways that we aim to do this is working at all levels. So working with the clinical community to highlight best practice and ways to address inequalities, working with grassroots and community organisations to reach the people that we want to hear this messaging, and working at general population level to raise awareness of these issues as well. We could go on to the next slide, please. Also wanted to highlight some of the key areas that are under-researched when it comes to the LGBT community and ovarian cancer. We just don't have the data to say whether lesbian and bi women and trans men are at higher risk of ovarian cancer or not. We know that NHS data from this year, 2021, shows that excessive alcohol and tobacco use is more prevalent in the lesbian, gay and bi adult community, but not in terms of, there is also no reliable data. So we just don't know these risk factors, we just don't know whether these risk factors, whether it's a correlation or whether we can actually say that lesbian and bi women and trans men are at higher risk of ovarian cancer. We also don't know, we don't have reliable data on whether lesbian and bi women on the use of the contraceptive pill by lesbian and bi women, which we know can be a protective factor of ovarian cancer. We also cannot say whether the use of testosterone hormone therapy increases the risk of ovarian cancer, which is something that is really important for the community to be looking into, as we need to know whether a full bilateral salpingo-oophorectomy is recommended to mitigate the risk if the case were that increases risk of ovarian cancer. But current research has not been shown to identify, it has not been shown to affect the cancer risk. And finally, now that several lines of evidence have shown that high-grade serous ovarian cancer, which accounts for most cases of ovarian cancer, originates in the fallopian tubes, And we just don't know the extent that people are having their fallopian tubes removed when having a hysterectomy as gender-affirming surgery, as best practice for the surgical approach has not been studied. And this is really important for us to know, because both historically and currently, we just don't know the size of the risk in this population, and the lack of evidence-based knowledge on this intersection of cancer care and gender-affirming surgery means that it's difficult for trans individuals to make informed decisions about their treatment. Go on to the final next slide, please. And here are just some of the key points that we wanted to reflect on in terms of what we should be considering when it comes to the LGBT community and ovarian cancer. As we've demonstrated, the LGBT community are not a homogenous group. The needs of a trans man, support and information needs of a trans man are very different to that of a cisgender lesbian woman, and we need to treat that as such and listen to and be respectful of all views, and be communicating and using language that is inclusive of all people, and therefore speaking to some of the more marginalized people in this community. And also, when we are supporting the LGBT community and putting information out there, really making sure that that we are moderating platforms properly, and providing a duty of care to this community, and not putting any information out there that could be triggering or upsetting. And I think here I was just going to hand over to our CEO, Victoria, to just speak a little bit more about addressing any challenges in this work and how we've done that.
Hi, hello. So this is the bit where I get to follow up. I get the good bits. Francis, I've seen your question. I'm not sure whether or not I'll be answering it during kind of my closing bits here, but if not, then I'm very happy to pick it up. I'm sure Stewart and I can between us. I guess for us at Ovacome, it has been a journey. What I would say is, in terms of our organisational approach, this has been very much led by staff. Staff in partnership with members, so those who use our services, but actually the driving force for this has been the staff. In order to actually get this ball rolling and start to become more inclusive and do the piece of work, we had to acknowledge that it's not always supposed to feel comfortable. We are supposed to feel challenged, and we are supposed to feel uncomfortable at times. And from an organisational perspective and a personal and professional perspective, I would say it is certainly worth doing. And we wouldn't be very proud of ourselves as an organisation, as a support organisation, if we weren't doing that, if we weren't being inclusive of all members of our community. So with that in mind, I think, you know, it's worth making the point that actually everybody needs to be on board with this. But actually, if it's driven by a staff team who are fully committed and passionate about addressing inequalities and health inequalities, then actually it makes it much easier to move forwards more quickly in a more empathetic and considerate manner to those who we are trying to amplify the voices of. I'd also say, just pick up on the resourcing issue, because whenever I talk to other CEOs about addressing health inequalities, the thing that I'm always kind of asked is, but how do you resource this? We made the decision to do this piece of work. We made the decision to become more inclusive. And then we looked for ways within our existing budgets to actually start the work. We didn't wait until we had specific funds in to do this. We drew from our existing comms budget to improve our inclusivity and the way that we were kind of promoting the organisation and the way that we were providing case studies. We drew from our existing support service budget to ensure that we were being more inclusive. We drew from our training budget to ensure that all staff were trained in being inclusive and understanding LGBT+ issues. And that enabled us to move forwards more quickly than if we'd have kind of sat back and waited and written an application and then sort of started from fresh. It also enabled us to learn alongside the community as we went. And it meant that the LGBTQIA members of our community were included right from the start. So it was centered on them and their needs, which I think is really important. What I would say is we are not claiming that we're perfect. I get things wrong all the time in this. In my language, I've had 46 years of learning to speak one way and a couple of years of challenging myself to do it differently. What I would say is what we try to do at Ovacome is when we get things wrong, we apologize, we do it quickly and we do it unreservedly, and then we learn from it. And when we don't know, we ask. So I think humility and the need to apologize often is the basis of the way that we do this work. And then I just wanted to finish. So Imogen just read to you the quote from the member, so the case study, the person that came to us and asked us why we weren't doing better when it came to representing same-sex couples, which started us on our journey towards being more inclusive. More recently, we had an email exchange from her. She emailed me to say, so this is your contrast. That was the start of the work. That's what set us off. This year, she said, I still get the Ovacome magazine. I still follow you on Facebook. I dip into your website every now and then. It's great seeing what you are and have been doing. I'm so pleased and I'm so very proud to have played a part in that and to have helped my community. So it's worth doing. And thank you very much.
Amazingly said. And I think it also shows from hearing Imogen and Victoria talk how there is that unity of voice through the organization. And I think this also comes to what a couple of people have asked about how do you take this up with people, and this moves nicely onto my closing thoughts about challenging people. And this also comes into the idea of a culture change and making sure that you're also able to hold each other to account if somebody gets something wrong, if somebody lets something slip. And this also comes into the aspect of sometimes when we're trying to be inclusive, we can get caught up in this aspect of being able and capable and being able to always get it right. But really, it's better to switch into the concept of humility, to understand you're not always going to get it right, and that it's a lifelong learning process. Because if we trick ourselves into believing that at some point we're going to master something, we can get complacent. And some people may feel they've reached that point when perhaps they haven't. Whereas if you foster a culture of humility inside, you're going to be much more able to take on not only the work that's needed to be more inclusive, but also the potential changes that might come from the community as they evolve and they change the way they want to be referred to. Or when you reach intersecting values and you have to learn how do you bring together two pieces of work you've done about how to be inclusive and pull them into one unique stream of thought. So with that in mind as well, it's important then to also think reflectively about everything. And although it does seem like quite a lot of work, especially in the idea of resourcing, but looking at things like the language in your organization, and obviously we've heard this case study about how to feel like you're seen in the media, seen in the newsletters, seen in the updates. And this also can come down into the visual imagery you use all the time. You know, are you constantly having pink things splashing everywhere with flowers, etc.? It's a style choice, it might be a brand decision, but it might be worth reflecting on it sometimes, or particularly in other pieces of media you make. The other thing I'd also suggest for people to do is also think about inclusion in your core content. So it's very good to start very much with small projects on the side, but as soon as you can, bring it into core values and core content, and make sure you're writing in your inclusive considerations into all your information pages, just so that people don't have that implicit bias that actually we're still considered separate. And then I just want people to think as well how they can think about the power and privilege they might have, especially if they're high up in an organization, especially if they're white, especially if they have a particular education or different way of moving in society, if they're cisgender, and how you can use that to help other people who might be in minority positions and people who might be in intersecting minority positions. So with that in mind, sorry, Victoria, you're not on the last slide. I didn't have time to fit you in. But if you want to get in touch with Victoria, you can do it via the website, and Imogen obviously can put you in touch directly, but we've got some contact details there. And I also just want to open up to a couple of questions. So first one I'm going to quickly go to was somebody asking, how do you recover from a pronoun error? Very good question, happens all the time. I'm very LGBT, the whole rainbow, and I'm getting mistakes all the time, even sometimes friends. The important thing is to understand it does happen. It can be a slip of the tongue. It can be a learning curve. Somebody's pronouns may have changed in the time you've known them. The way I recommend recovering from that error is I have a little system of AA, double C. And what it means is apologize, So first, realize you've made a mistake. You don't have to overdo the apology, but just say, oh yeah, my bad. So apologize. Next one is ask. Ask them, okay, well, which pronoun do you use? Or how do I do this correctly? If you're unsure, it's okay just to say, okay, just tell me how to get this right. And then comes the double C, which is reflective. So this is correct yourself. So when they've told you, actually, I prefer to use they, them, great. Repeat what you're going to say with the right pronouns. Make sure you can show you've changed your behavior. And then the last one is to commit to it. So commit to that change. Don't expect that person to keep reminding you. Take it on board and say, yep, I've got that. And I'm going to make sure that I get it right next time. And sure, you may slip up here and there, but as long as you go through that double A, double C method, most likely you'll be able to get around any awkward interactions. So we've touched lightly on how do we address people who potentially are challenging efforts. I think it's very good to remember that as much as you can to try and get that culture of humility, understanding internally, especially because when we are running organizations, we are in positions of power. And when we think about beneficiaries accessing our services, they may not all have the strength to tell us when they're unhappy with the way they're being spoken about or the way they're accessing things. So it is important to remember that as much as you can show inclusion at all levels, it's going to open doors. But I also wanted to come to Victoria about the fact that sometimes there can be barriers for people when you start becoming more public online about your inclusion practices. And unfortunately, recently, this can get a bit of a backlash, but I think Victoria's got a really good view on this.
Yeah, I mean, I think, so when we, little example, essentially, when we ran our Pride campaign this year, we were very, very vocal about talking about people with ovaries. And people, and it's language that we've used consistently now for the last couple of years, actually. But because we were running such a public Pride campaign, and because we had new resources and we were pushing information quite a targeted way to members of the community who we knew probably were not aware of some of the issues, we did have quite a major backlash on social media. I think as CEO and with the Board of Trustees and as a staff team, we talked about it before this. Okay, so we knew that, you know, some people may see us as having been provocative, for example. Actually, we're fully committed to this change. We're fully committed to supporting all members of our community. And if that means that we have to have uncomfortable conversations, if that means that sometimes we have to, you know, spend a lot of time on social media explaining things, or, you know, kind of dealing with difficult people who you know, don't particularly have any interest in ovarian cancer, but nevertheless feel they want to be vocal or be difficult, then, you know, that's just a part of the journey. But ultimately, I think as an organization, when we look at that, the one prevailing reaction and response that I had from the trustees and the staff team in that was they all said, individually and independently of each other, they all said, well, if we're feeling this level of antagonism from people who want to give us, you know, their opinions on, you know, who are essentially transphobic, if we're feeling this level of antagonism in our working practice, how must trans people be feeling now? And if we approach it from a place of empathy and a solid position where we remain committed to, you know, bringing about the change and being more inclusive, it's not a half-hearted commitment. It's a full commitment. We're going to do it or we're not going to do it. If we're going to do it, we're going to do it properly. So I think in that sense, the staff team were really proud. They were really proud, and we had great feedback, and the fuss died down pretty quickly. And we were able to engage in a really positive and, you know, in a lovely way with the LGBT plus community as a result, because they saw that we'd been protective on the social media channels, you know. So I think, you know, it's always going to be challenging, you know, and in working with our partners as well, sometimes we push back, and, you know, some of our partnership resources, you know, are problematic because some of our partners haven't been on the same journey that we have. But I think it's about that, you know, maintaining that position and just having the integrity, making a commitment publicly, and then seeing that through, even if it's difficult.
Yeah, definitely. And we had a couple of questions as well about how do we get started on being inclusive? And I think a really good thing to think about sometimes is, rather than think about how you first get your toe in, think about it on a macro and micro level. So think about it on the macro sense of where do we want to be? What organization do we want to be? And how can we support people? And then pick a rough timeline so you know where you're heading. And that way it's much easier to get everybody on the same page. So rather than thinking as a team, oh, now we've got to learn this, and we've got to do that, and we've got to learn all these words and this new sort of way of speaking, as long as everybody understands the final goal, you know you're going to get there. And then you can work backwards and set your SMART goals and make sure that then people feel like there's a route to progression and that you're able to sell the concept of what a final product of a supportive organization is going to look like. And one of the really good things to actually focus on in one of the earlier steps is language and fluency. And I say this because as an LGBT patient, the first thing I notice when I go to another organization is if they can't say LGBT fluently, they're not saying it enough. And I don't care how many times they say they're doing it in their EDI practices and they've updated a policy, it really shows if someone's not able to speak fluency on a topic. And we know this as well because we obviously work in aspects of health that have very strange names and drug names and tumor names. We're able to learn these things. So if you're not able to speak on very small parts of our community language, it shows that you're not bringing it up in your meetings, you're not talking about it with your colleagues. And a really good way to practice that is to talk about it more. Talk about it amongst yourselves, make it a very normal conversation so that when people access your services, there aren't any necessary sort of trip ups or any awkwardness that might potentially be read as a microaggression by somebody accessing your services and therefore may become an additional barrier that you really didn't intend. Another point that Victoria touched on is also thinking about, okay, if we're having a hard time as an organization taking the sort of flack from potential parts of the public about our change, how is this affecting actual people accessing services? I would also add into that as well, if you have decided inside your workforce, okay, well, we have this LGBT member of staff that is able to take this on and they're very committed, and potentially the ones who haven't, if you are getting that potential pushback, make sure they're being looked after as well. Check in on their well-being, see if they need any additional support, because sometimes it can be even more upsetting when you have faith in your organization to do the right thing, but then you see this pushback. So just make sure that everyone in your service is being looked after. The other thing that's sort of come out as well when you all did the poll earlier is we could see that a lot of people felt like they had a good amount of knowledge, but lacked confidence. And I do genuinely believe that some of that comes from not having this fluency, not having this familiarity. And the more that we normalize these conversations, the more that your confidence will go up because you'll have practice in discussing these things. And myself as a charity who'd lived through this, we're very open to people contacting us, accessing our resources, talking together about how to actually create this idea of a picturesque future that we're all trying to get to. So feel free to stay in contact with us, email us directly, etc. And as much as our capacity allows, we can try and help along the way. And I'm sure Victoria feels the same.
Yeah, for sure. I mean, if anybody, wants to get in touch, talk about it further, use our resources, some of the web pages we got, for example, or talk to myself or Imogen, by all means.
Yeah. And then there's a really great final question I want to end on. And somebody has asked, is it okay to have multiple streams of information tailored to different audiences? And I think sometimes, yes, there is going to be a time that you're going to want a specific piece of information specifically for an audience, so they know it's just for them. That makes perfect sense. I think sometimes it's just also then thinking about, again, sort of the macro version of, okay, let's look at our core content. Is our core content written in a way that everybody can read it? And then from that, you can start branching of like, okay, well, potentially this thing is a bit too intense for this core content. Let's make a separate subpage. Let's make this. So I don't think there's anything wrong with having different streams of information targeted at different people, but I think it is good sometimes to reflect on your core content and think, is this also appropriate for everybody? And we are right up to the last minute. So thanks for your attention, everyone. It's been really nice to sort of talk amongst ourselves for your benefit. And I hope you've all enjoyed it. And I'll let Victoria and Imogen sign themselves off as well.
Thank you very much. Look forward to working with anybody who wants to work with us on this.
Likewise, thank you very much, everyone.